We ready? Because these next panelists are absolutely amazing. I was just back there, and I'm very, very impressed. So I have to put on my glasses so I can get everything together. So our next segment is about sarcoidosis, which is, it's more than just a nagging cough. Now, we're about to uncover mysteries of the disease of sarcoidosis in the enlightening section that's featuring some esteemed experts on this condition. Dr. Sanjay Shukla is President and Chief Executive Officer of Attire Pharma, where he also serves as the Board of Directors, and Dr. Sanjay, as I love to call him, previously served as a Chief Medical Officer of Attire. Please, let's welcome him as he comes out. Howard University Medical School, I gotta give him a special shout out. HU, you know, oh, okay, so we're all in the house, okay. All right, and Dr. Shadinma Chima Melton is a board-certified pulmonologist and assistant clinical professor, Division of Pulmonary and Critical Care Medicine for UCLA Health. Let's give her a round of applause. And also with us, we have Andrea Wilson, who is a sarcoidosis patient, and she is a leading advocate for patients with sarcoidosis, and she co-founded the Foundation for Sarcoidosis Research, FSR, in 2000. So please join us as we delve into the latest research and strategies. Thank you so much for your advocacy. As we delve right into these complex conditions. So welcome, panelists.
Welcome.
Thank you.
Thank you.
I'm Sanjay Shukla, President and CEO of Attire. We're right down the road in San Diego. And here to talk to you about a really important topic that sometimes gets ignored, but not in this community, and that's sarcoidosis. So if we could flash the first slide, Ashley. Attire is a company that is committed to developing a therapy in sarcoidosis. And these are just some people that you may know have or had sarcoidosis. What do they have in common besides having sarcoidosis? You can see this is a condition that impacts the Black community. I learned about sarcoidosis as a medical student at Howard about 25 years ago. And I've been in drug development for the last, say, 25 years at big companies, small companies. But at Attire, we found some intriguing signals with a therapy about 7 years ago that we have carefully moved forward through phase 1, phase 2, and now phase 3 testing. And I'm proud to say that we have the closest therapy now to potentially get approved, currently studying this in a phase 3 trial that I'll talk to you about kind of at the end of the presentation here. But obviously a lot of prominent celebrities and folks that you know, even recently, with Crazy Bone, he's been in the hospital with sarcoidosis. So it's definitely a condition that is pertinent and relevant even with current events. So I'm going to now turn a little bit towards diagnosis, just what is the disease. I'm going to turn this over to Dr. Melton, who's going to talk a little bit more about sarcoidosis, what is it, who gets it, what we have to deal with sarcoidosis, and what are maybe some of the treatment options.
Thank you, Sanjay. So this is a topic that's really close to my heart because it's a disease state that is in my field as a pulmonologist, and it affects my community. And so this is really under-recognized, and that's the reason I'm sitting here today. It's a condition that is very prevalent in the US. About 200,000 patients in the US have it, and we have about 1.2 million people worldwide. What is really striking here, though, is that it's so prevalent in our community, in the African-American community. It's 3 times as common. So if you're looking at the epidemiology of it, they tell you, oh, your sarcoidosis is about 10 in 100,000 patients will have it. But within our community, it's 34 in 100,000 patients. So it's 3 times as common. And not only that, it's more common in women as well, twice as common in women. And so we have a higher prevalence of the disease, but it doesn't end there. Unfortunately, when we do have the disease, we also have worse forms of the disease. So we see more breathlessness, we see more shortness of breath, we see more cough, and we see more progression to the fibrosis, to the scarring in the lungs as well. I'm going to take a step back and just kind of poll the audience a little bit and find out how many of you had heard of sarcoidosis before today? Quick show of hands. Okay. How many of you know somebody, personally know somebody who's living with sarcoidosis? Show of hands. Okay. And how many people actually have sarcoidosis here? Okay. So you can see, this is not surprising to me. We have about, 200 people in here, and we had 3. So 1 in 40 people in the African American community have sarcoidosis. And this is the reported numbers. So if you think about the unreported piece of it, and I believe firmly that it's highly underreported, you likely know somebody that, I think every hand should be up here. You likely know somebody who has this disease. So if we flash those slides back up and we can continue talking about what that looks like. So thinking about the disease, what does it actually look like? What happens in the lungs? Well, the reality is we don't know why it's driven. We think it's some communication or some combination of genetic factors as well as environmental factors. But what's happening is that you have chronic inflammation in the lungs, chronic injury in the lungs, and it's immune-mediated, meaning your immune cells is what's driving it. And what happens is that they form together to form these granulomas, these collections of cells. And ongoing injury, ongoing inflammation leads to scarring. So just like when you cut yourself on your skin and you see a scar that builds up, exactly the same process happens in the lung. And sadly, what that means is that your lungs that are optimized for gas exchange, for you to get oxygen into your bloodstream, having scarring prevents that from happening. So you notice you're not able to breathe as much. Some people have a cough. That's the most common symptom. Some people feel more tired, just fatigue. Some people feel, really run down. But then 90% of people have it in the lungs. But then you actually have appearances in multiple other organ systems. It can affect the eyes. It can lead to strokes. It can affect the skin. I actually want to introduce Andrea because she can share some of her experiences as a patient because her condition was underdiagnosed and went undiagnosed for a long time.
That's right. That's right. Thank you. I'm Andrea Wilson. I'm a sarcoidosis patient and also a patient advocate. I have walked the challenging path that many of you sarcoidosis patients are on right now. In 1986, I had a nagging cough, fatigue, and unexplained weight loss, like we have just been talking about. For 8 long years, I sought answers only to be ignored and misdiagnosed with many different conditions, and some that I was actually treated for, even though this was incorrect. Finally, I was diagnosed with pulmonary sarcoidosis, and I was excited. I was finally thrilled that I was diagnosed with something and that it was not all in my head, it was not my menses, it was not the fact that I was a young 20-something-year-old woman and that it was stress, which I had been told. Yet I realized that the treatment options were very limited. And the number one treatment that I was given was steroids, or prednisone, which a lot of you may be familiar with. Over the years, I've had a heart attack, 2 strokes, and I've broken many bones, all while living with sarcoidosis. And I'm sure this sounds familiar to most of you. I've tried numerous treatments, from chemotherapy to biologics to Eastern medicine, I've tried just all sorts of crazy, medicines and things that were sort of people thought were a true fix for me, but nothing really worked. No one single solution worked. So with my doctor's guidance, we've created a multifaceted treatment plan to reduce my reliance on prednisone. And this is comprised of different diet, different sort of brews that I make at home. I actually brought one today. A mix of, things like ginger root, turmeric, cayenne pepper, a lot of these things that I'm sure a lot of you wouldn't go near unless you were really sick. So it's a mix of really living the best life you really can, the healthiest life you can, while reducing the number of drugs of prednisone that you can. So it has taken a while to come up with that sort of mix, but after being treated with all sorts of toxic chemicals, it really became a must-do for me. And I share my journey because I understand the struggles of proper diagnosis and seeking the right treatment. And as patients, it is critical to be proactive about your care. I'm also very passionate about being part of the solution. And I mean that as part of the solution not only for your healing, but of the larger picture of the disease which may afflict your family, your neighbor, your coworker. When I mention to people that I have sarcoidosis, this is the same disease that took Bernie Mac, a light goes off in their heads. Awareness about this disease is key. While my disease has progressed too far for me to participate in aTyre's EFSO clinical trial, it may not be too late for you. So I encourage you to take part in your care and demand to be diagnosed and stay positive. My dedication to advocacy remains unwavering, and together we can raise awareness to support research and improve the lives of those living with sarcoidosis. You're not alone in this journey, and I really do believe there is hope. We are the hope, and we need to be the catalyst for change, and a big change away from prednisone. Thank you so much.
Thank you for sharing that. So that was a very heartfelt story, and thanks for sharing your personal experiences with us. I think it's important to think about, so you have a family member or you think you know someone who has a chronic cough, they've been coughing for years. What is the next step? What do you do? And what does that journey look like for them? So let's talk a little bit about that. What that would look like is basically you have them go see their physician, go see their primary care doctor, and they usually start off with a chest x-ray, just a simple chest radiograph. And there's a very classical pattern that we see with sarcoidosis. Sometimes it's there, sometimes it's not, but often it can be there. And if it is there and they are symptomatic, we do further study, meaning we get a CAT scan of the lungs to actually get more detail about what we're seeing. If the findings, again, are not super confirmatory, then the next step would be biopsy. So they need to get a lung biopsy, and under that biopsy, they see the same thing we talked about there, which is the granulomas, these collection of immune cells that are clumped together. That is what we use to diagnose sarcoidosis. So let's say we've got the diagnosis of sarcoidosis. You have your loved one or yourself that has just received the diagnosis. What does that look like for you? We talked about hope here. 2/3 of patients can actually do well and sort of it's self-limited, meaning they don't necessarily need treatment unless they are quite symptomatic. However, 1/3 of patients do progress onto chronic disease, and these are the people we really want to intervene on. Because what chronic disease looks like is, as I mentioned, ongoing shortness of breath that limits your quality of life, and then eventually leading down to what we call respiratory failure, technical term for you can't breathe. You're walking around with oxygen, and then eventually, requiring a lung transplant if you're lucky, or unfortunately, passing away from it. And it's a horrible way to go. I have had, some patients where this has happened. So we want to intervene before we get to that severe fibrosis stage. And what intervening looks like, unfortunately, right now is steroids, corticosteroids. Most people get on prednisone or methylprednisolone as a steroid, and it helps reduce the inflammation. In 90% of cases, people actually get better with it. But the problem is, often the disease comes back once you try weaning off the steroids. And so, I don't know, how many of you have been on steroids in the past? So the challenge about taking steroids chronically is that it's associated with a bunch of bad stuff. Weight gain, blood sugars going through the roof, it's thinning your bones out, it thins your skin. There's multiple negative things associated with steroids. And so we know that we need more. We know we need to demand more therapies. We need to get better understanding of the pathophysiology of what's happening that's actually driving this disease. And so, thankfully, Dr. Sanjay and his group have a clinical trial that's in process right now that's doing exactly that. So I'm going to pass it back to you to talk about that.
Thank you. That's a great primer on a disease that even a lot of lung doctors don't maybe see a whole lot of. So specialists who understand sarcoidosis, really important to get diagnosed, really to not overlook some of these symptoms that Dr. Melton has talked about. But one of the things that occurred to me about 7 years ago was when I thought about embarking on this journey to develop a drug for sarcoidosis, is most of the community, and I'm talking about big companies or even investors, they would say it's not that bad of a disease. Those patients can just take steroids. And that just really bothered me, because to see what steroids can do to someone's life and having a patient have to make that choice, that I have to take this toxic therapy, in 50 years in the medical textbooks, they're gonna say, this was poison. And I also, unfortunately, probably know this, having worked at bigger pharmaceutical companies, there's other reasons why I think this disease has been ignored. And it shouldn't be. So we set out on a journey at ATAR to be very careful and craft a therapy that we thought might work. What I'm proud of what we've done is we've sort of slowly moved forward here. And we've done so with patients by our side. And we've learned from patients. Andrea was one of the first people I reached out to say, teach me about sarcoidosis and what really would matter to you with a new therapy. A lot of drug companies develop therapies that might change a biomarker or something in your blood. But our goal really at ATAR was to really change the quality of life for patients. So we developed a therapy, and I don't want to spend too much time on this, but called efzofitimod. It's a mouthful, I know, but this is a therapy that's really targeting the chronic lung inflammation. We believe this is a therapy that could potentially safely reduce steroids, improve quality of life, and actually make your lung function better. That's the kind of medicines we need, things that really change patients' lives. And I think many times in the pharmaceutical world, they are producing excellent therapies, but they just do moderate things to improve the quality of life with patients. This should have a dramatic effect. We started by testing things, obviously, in animals to make sure the drug is safe, because you don't want to replace a toxic therapy with a new drug that also creates other problems for patients. So 5-6 years ago, we looked at healthy volunteers, happy to pass that test. We then moved on to a patient trial that actually, we saw some really extraordinary benefits. As expected, we thought the drug was going to be safe, but we also saw some real improvement in lung function and the quality of life. Patients coughed less, they had less fatigue, they had less shortness of breath, and they were able to get off some of the steroids. So it's exactly what I wanted to see. That was a small study that we wrapped up and we published in a major medical journal about 2 years ago. So where are we now? We've made history. We're the first ever therapy to get into what's called phase 3. And this is really where the rubber hits the road. Thank you. It wasn't easy to get to phase 3, but right now we're in about 80 hospitals around the world, and we are enrolling in a rare disease. But what I can tell you is the drug doesn't get approved unless its patients get motivated. And having worked in areas like lupus, that community got a drug approved because of the patients. Had nothing to do with the company or anything like that. The patients standing up and saying, I've had enough of this. I'm not taking steroids anymore, and even some of the other more toxic therapies. So we've moved into a phase 3 trial. Here in Los Angeles, we actually have a center at USC. I would encourage those to, if you're interested, to learn more about the therapy. We're really trying to reduce that steroid burden, that toxicity. There's a number of criteria here that we can, I don't want to really get into today. This is really not about that. But I will say that if you know someone, if you know someone, even nationwide, I think there's a slide looking at all of the centers around the country. This is a real group effort. To get across this finish line, we need about 264 patients. That's not easy to enroll. What I tell all the patients is I can't promise if this therapy is going to actually work or be curative. But what I can promise you is no matter what, we're going to learn a lot from this clinical trial. And sometimes what happens is if you learn a lot, companies that follow you or even, we try again, you can actually get to that finish line. I think we're on the cusp here of doing something special. It will have taken about 10 years, but that's how long it takes to actually develop a compound safely. So with that, I think we can answer any questions. Dr. Melton certainly can answer more questions about sarcoidosis. I think there's a QR code up there too, if anyone is interested. And I'm around as well if folks want to understand more about the therapy or even participating in our research. So thank you for your time. We can take questions.
Please go up to the microphone if you have a question. They're on both sides of the room.
Yes, I wonder why the age limit is 75. My mother's 89. She's never been diagnosed with it, but she has been diagnosed with shortness of breath for the last 15 years or so. And prednisone helps, but her doctor does not want to prescribe it to her on a regular basis. She knows she feels better when she takes prednisone. She's on a couple of inhalers. And so, yes, is there a reason why it's 89 and are inhalers a type of steroid?
Yeah, so I'll answer the first part about the trial, and you could probably talk about inhaled steroids. So many times, one thing you want to do in a clinical trial is you want to do no harm. You do not want to harm the patient in any kind of way. And even in our study, we're very, very careful about managing patients and making sure that they have no new safety findings. In an elderly population, once you start to become 80, 85, and even in a pediatric population, you have to be careful about what a drug does because you don't have any evidence about what it might do. And the physiology of a young patient or a very older patient can create some risk, even the best therapies. So working with the FDA, working with European regulators, Japanese regulators, we set these cutoffs because we're just not sure if you give it to a patient who's 80 or 85, how they might react. Our normal physiology changes as we get older. So this is to safeguard some of those patients. But this is something that I've been asked many times where patients have said, I'm 78, I'm 80, I'd like to be in the trial. But unfortunately, we want to, regulators, and rightly so, want to keep patients safe in a trial. And I tend to agree with them. You want to talk a little bit about inhaled steroids and what role they may or may not play.
Absolutely, yes. And I just want to add on to that, what you were talking about in a bit more detail. As we get older, the way our body functions changes. And for example, your renal function doesn't work as well. Your kidney function doesn't work as well. And so, you want to try and find the most sort of normal group, quote unquote, normal group of people that you're studying so that way it can be as broadly applicable as possible. And so that's often why certain groups get left out of studies, not because we don't think they may benefit, but while you're trying to figure out the impact of a program or of a drug, you want to make sure you're studying as representative a group as possible, at least initially. Okay. And then in terms of sort of speaking directly, everything, obviously I'm not your mother's physician, so everything I say is sort of taken with a grain of salt. But it's not uncommon to have asthma, for example, appear as an adult, older adult onset asthma. If she has ongoing shortness of breath, I would encourage you to, if she's seen her physician, primary care physician, request a referral to a pulmonologist, because this is something that needs to be worked up a little bit more. Older adults can have shortness of breath for a wide variety of reasons, many of them being lung problems, but some of them might be heart problems. Some of them might be immune reasons. We don't know why, so I think really probing a little bit deeper and having a specialist assess her is going to be really key. You asked a third part of the question there, which was around steroids and inhalers. There are some inhalers that are steroids, and these are really inhalers we use for patients with asthma, which is why I started talking about asthma. But we want to make sure that that's what you're treated in the first place. So this is why the diagnosis is so key, because it changes quality of life. If she's treated with the right medication, she might be more active, more mobile, and able to participate more, joyfully in her life. And then the last piece I'll mention is, if she does have an underlying chronic lung disease, one thing we know that improves not only quality of life, but actually outcomes, meaning you live longer, is pulmonary rehab, which is an exercise program geared towards people with lung problems. So a lot of primary care physicians are not aware of it, and they are not aware of the benefits of it as well. And so this is another reason she wants to see a specialist for it.
Thank you. I really want to say this is very helpful because, for years we've known she's had inflammation in her lungs and shortness of breath, but we haven't known really what more to do about it. And just what you said, there's treatments for it, and that we need to find out really what's causing it.
Right.
Because she doesn't have asthma and they don't know, but we do know there's inflammation. And thank you. I would like to ask why it affects the Black population more, and why the researchers were less likely to address it. And keep in mind, a lot of our population does live in their 90s. And so they're still healthy in their 80s. So that cutoff might be a little bit, short for some. But anyways, thank you.
I mean, I can take a shot. Oh, you should comment as well. I think when we think about why it may impact the Black population a bit more, I've been thinking about this for the last 6 or 7 years, and there was always this notion that perhaps genetics and race play a role. But the more I've really dug into this, I think sometimes access to good healthcare and even really experts play a big role. You look at other diseases like idiopathic pulmonary fibrosis, a group at University of Chicago noticed that if the Black community on the South Side had better access, their outcomes got better. So I don't think it's purely just something related to race that might have been suggested in the past. But I don't think we know absolutely. We know that environment can sometimes play a role. There's a bit more, east of the Mississippi, and certainly in the Southeast, you see a bit more. But because we don't know the real cause, most of the 9/11 workers who cleaned up all the debris, down there with that toxic matter, they developed a very aggressive form of sarcoidosis. So, I think we don't know yet. So I think it's a little quick to maybe just think about genetics here. Access probably plays a role.
I totally agree. Thinking about genetics, we know that there's about 10 to 15% that we see concordance in families, meaning that in some situations, like 10 to 15% of the time, you will see there is a family member, first or second degree family member that has sarcoid, but that's just the minority of it. Most of the time, there is no one else. This has come out from the clear blue sky. So we know there's clear environmental triggers that is probably leading to this as well. And so, I tend to agree with Sanjay, I think, knowing that perhaps we are under-recognizing it in certain populations due to historical challenges. I'm just going to say it, structural racism that's existed. And we are in a situation now where we are seeing more and more of it. And now the recognition's there, if we continue diagnosing it and treating it. The second part of your question was why it hasn't received the research dollars and research that it has, that other disease processes have. To be honest, I tend to be an optimist most of the time, but I do think a large part is due to the population it affects. In fellowship, I did a lot of research around the lung disease process called interstitial lung disease. It was IPF, idiopathic pulmonary fibrosis, which is a disease that affects predominantly white men. And the reason the lab I was working in chose to do that was because the research dollars were there. And so there are certain research topics that are funded better than others. And unfortunately, up until this point, sarcoidosis has just not had the attention that's due to it. And I think that's why we're all here to basically demand that, companies, organizations, governments start taking our community seriously and start putting the research dollars so we can actually treat our people.
We may be up on our time, but I have a question here.
Very quickly, you said you were misdiagnosed over time.
That's
What
right.
were some of the misdiagnoses that you received?
I was misdiagnosed with MS, a brain tumor, Meniere's disease. Those are the ones that come to my mind right away.
Okay, thank you.
And, you know, that's actually a really important question because sarcoidosis, we call it the great mimic. There's two diseases in medicine we call the great mimics. One of them is sarcoidosis, the other one's tuberculosis. And the,
Sorry, tuberculosis too.
yeah,
That was another one.
and yeah, which makes no sense because, anyway, and the reason why, let me finish this and then I'll take your question. And the reason why is because when you do imaging, it can look like anything. And in some cases, it even looks like cancer. I've had patients who come in crying, thinking they have cancer. We biopsy them, we find out it's sarcoidosis. So I think having that index of suspicion and getting the right diagnosis is so key. So go ahead with your question, please.
Yes, I'm a healthcare advocate. And when you mentioned Bernie Mac, the renowned actor, when we went on the internet, it said that he had been in smoky bar rooms, I guess from comedic acts, and he did smoke cigars. Could that be one factor of cause and effect?
That's a great point. So sarcoidosis, we know that there are certain things that increase the likelihood of you getting it. And smoking is actually one of them. When I have a patient that comes in with sarcoidosis, the first thing I tell them before offering therapy is you have to stop smoking. And this is not just true for sarcoidosis, it's true for any lung disease, and dare I say any disease, period. You know, smoking unfortunately makes everything worse. So yes, smoke exposure, whether it's direct smoke exposure or secondhand smoke exposure, is a risk factor, documented risk factor for sarcoidosis.
Thank you for the questions. We're over time. Appreciate all of the interest, and we're committed again to hopefully get this over the finish line. Thank you again.
Thank you all.